But I'm really delighted to be invited to be part of this panel. It's a great audience. I'm not sure if I would have woken up in time to come here if I weren't presenting, but thank you everyone for attending. So my goal is to talk a bit about some big data approaches to measure social inequities and to examine them in relation to health disparities and in particular racial inequities in health. Big data in particular can be utilized to characterize geographic areas. Data sources include administrative data, such as the census, to describe patterns in, for example, racial residential segregation or racial isolation. There's increasing use of other data sources, such as large-scale data from social media and other data from the internet to describe geographic variation in underlying population attitudes. People have also used other large-scale administrative data to measure institutional forms of inequality. And these have been linked to health data. And looking at this health data shows that health is not distributed evenly in a population. And these observations are not new. This is a quote by Rudolf Virchow, one of the founders of the field of social medicine. Medical statistics will be our standard of measurement. We will weigh life for life and see where the dead lie thicker, among the workers or among the privileged. So indeed, the dead do lie thicker in some groups compared to others. We can use big data from death certificates, for example, to illustrate these inequities in the population-level distribution of health and things like death. This is a map showing life expectancy in the US. People in lighter shades of blue die earlier compared to those in darker shades of blue. I am at Auburn University, which is in Alabama. Is there anyone from Alabama here? Yeah, okay. Well, so I've been in Alabama for about 3 years. And what I've learned since moving there 3 years ago is that Alabama is an incredibly unhealthy state. Life expectancy in Alabama is about 3.5 years lower compared to life expectancy in the US as a whole. In fact, Alabama exceeds only 2 other states in terms of life expectancy. Do you folks know what those states are? Mississippi and West Virginia. And so I learned since moving to Alabama that one of the state mottos is thank God for Mississippi, because we're not sorry for folks who are from Mississippi, but if it weren't for Mississippi, we would be dead last on a lot of these health metrics. So why is Alabama so unhealthy? So when I ask people this question, the typical responses tend to be behaviorally based explanations, so things like sedentary behavior or poor diet or smoking. But then can we ask, what is it that makes Alabamians more prone to engage in these unhealthy behaviors? So while poverty is one of the main risk factors for poor health, and Alabama is one of the poorest states. I've learned that Alabama does not have a state minimum wage, so it relies on the federal minimum wage, which is $7.25 an hour. So for someone working full-time, making the minimum wage, that would be $7.25 an hour times 40 hours a week times 52 weeks in a year, and that works out to a little over $15,000 a year. So the poverty threshold for a single person under the age of 65 is about $13,000. So someone working full-time, making the minimum wage, would be very close to that poverty threshold. For someone who has a child, that household would be considered living in poverty. Another thing that I learned about Alabama is that it's one of only 3 states that charges the full sales tax on food. So a sales tax on food means that poorer people are having to pay a larger share of their incomes just to survive. So in general, sales tax is highly regressive, and Alabama has one of the highest levels of income inequality in the US. So again, I'm at Auburn University, which is in Lee County. And Lee County is not doing too badly, at least compared to the rest of the state. But notably, life expectancy is still lower than the US average. But look at Macon County, which is right next door to Lee County, where life expectancy is almost 4 years less. So what we see from these maps is that there's considerable heterogeneity in health between states as well as within states. Examining individual health requires not only understanding individual characteristics, but also the characteristics of context. And this is something that we refer to as contextual versus compositional effects. So context matters. Where we are born, where we are raised, where we work, and where we live all matter for our health. And in the US, where we live and the conditions we live in are highly correlated with race. So in Lee County, 71% of the population is white and 22% of the population is black. In Macon County, these numbers are essentially reversed, with 82% of the population being black and 15% being white. So racial residential segregation is endemic in the US. This is a map of New York City, the largest city in the US. Here, the blue dots represent whites and green dots represent blacks. And so we can see that where you live in New York City is highly correlated with race. And using geocoded race data from the census, we can quantify this level of unevenness. The black-white dissimilarity index in New York City is 78%, meaning that almost 4 out of 5 blacks would have to move from their census tract to a different census tract in order to be distributed evenly with whites. So again, 4 out of 5 blacks would have to move from their neighborhood to a different one in order to be distributed evenly with whites. So not surprisingly, the areas that blacks live in look very different from those that whites live in. Blacks live in tracts that have on average more than twice the levels of poverty compared to the tracts that whites live in. So these patterns in racial residential segregation and poverty concentration are common across metropolitan areas in the US. These next maps are for the next 4 largest cities in the US. This is Los Angeles, Chicago, Houston, and Philadelphia. This is a map of where we are now, the San Francisco Bay Area. We see that blacks, again, represented by the green dots, are concentrated in the East Bay and specifically Oakland. And here the dissimilarity index is 62%, meaning that about almost 2 in 3 blacks would have to move from their neighborhood to a different neighborhood to be distributed evenly with whites. This is a map of our nation's capital, Washington, D.C. Here also we see a stark separation between where whites and blacks are living. By the way, this orange hand waving in the center of the map is where our National Adult Daycare Center is located. So what these maps show us is that blacks in the US have been largely segregated into areas characterized by worse physical environmental factors and deficiencies in the service environment. And these conditions result in less access and worse health care, diminished socioeconomic opportunities, and generate differential patterns in health behavior. Racial residential segregation has been linked to negative health outcomes. This is a recent systematic review and meta-analysis which found that black mothers living in areas characterized by greater racial residential segregation and particularly racial isolation were at higher risk for having adverse birth outcomes. So one question you might be asking at this point is, why do we see these patterns in racial residential segregation to begin with? So these patterns are perpetuated by contemporary forms of racial discrimination in housing, but are largely the result of a legacy of slavery, subsequent migration from the South after emancipation, and ensuing forced separation. This is a map of the concentration of slavery in the US South. So slavery was not distributed evenly in the US. And what Michael Kramer and his colleagues found is that current day patterns in heart disease mortality map onto differences in slave concentration. So one possible explanation for this finding is that historically, disinvestment in areas with larger former slave populations have led to structural disadvantages that continue to have ramifications today. This has resulted in current deficits in the physical and the service environment. We can also quantify social environmental toxins, such as racism. To examine racism in different geographic areas, my colleagues and I utilized a measure that leveraged a particular big data source, Google search queries. So I'm amazed at how much Google knows about me. Like, how did you know I wanted that duvet cover? But specifically, we examined the concentration of Google searches containing the N word. And so that's the N word ending in ER or ERS. We excluded variations of the N word ending in A or AS. And we use this measure as a proxy for the degree of racist attitudes against blacks at the designated market area or DMA level. So this measure doesn't require that all Google searches for the N-word are motivated by racism. Rather, it only assumes that individuals who conduct searches for the N-word are on average more likely to hold racist attitudes compared to those who don't. And leveraging big data, combining searches across multiple years still yields a pretty good signal-to-noise ratio. And what we found was that each standard deviation increase in this Google search-based proxy of area racism was associated with an 8.2% greater black mortality rate. This translates into roughly 30,000 excess black deaths per year. This relationship persisted after adjustment for other area-level factors, such as urbanicity and the percent of the black population, adjusting for socioeconomic measures, such as education and poverty. In our final model, we adjusted for the white mortality rate. By doing this, we were controlling for possible unmeasured confounders that might influence mortality overall in a geographic area. We are also starting to now tap into black-white disparities in mortality. And still, we found a significant association between this Google search-based proxy of area racism and black mortality rates. We then looked at specific causes of death and found significant relationships with the three leading causes of death among blacks, that is heart disease, cancer, and stroke. In another study, we looked at birth outcomes and found significant associations with both preterm birth and low birth weight among black mothers. Others have also started to look at data from the internet to capture underlying population attitudes. For example, this is a map of social media data, specifically of homophobic tweets, with those areas that are lit up in red having a higher concentration of homophobic tweets. Tu Nguyen and colleagues conducted sentiment analysis on almost 1.25 million tweets, and she found that those states with less positive racial minority sentiment, as indicated by tweets, had a greater prevalence of low birth weight and preterm birth. In addition to social media data, we can also turn to other big data sources used specifically for research to capture racial attitudes. For example, this is a map of implicit racial bias measured using the Implicit Association Test, or IAT. For those who are not familiar with the IAT, it is a performance-based measure of implicit or unconscious attitudes. And using data from Project Implicit, which contained over 1.7 million responses to the IAT from all 50 states and Washington, D.C., Leitner and colleagues found that those states characterized by greater levels of implicit anti-black bias spent less on Medicaid. Data from Project Implicit has also been leveraged to look at other forms of bias at the geographic level, including anti-gay bias. This is a recent study that was published in PNAS, which found that implicit attitudes towards gays improved following the passage of gay marriage legislation. So importantly, I think this points to the role of policy in promoting social equity. Other big data sources that could be used to measure institutionalized forms of bias include administrative data from the Home Mortgage Disclosure Act database, which includes mortgage loan information across the US, and could potentially illuminate discriminatory lending practices. Gilbert G. used this data to characterize redlining among Asians and linked this to poor health status among participants in the Chinese American Psychiatric Epidemiologic Study. Abigail Sewell and colleagues utilized policing data, specifically administrative data from the 2009 to 2011 New York City Stop, Question, and Frisk database, which contained information on over 1.8 million stops. And so what they found was that neighborhood frisk and use of force was linked to greater psychological distress among men. And so these findings suggest that living in an area characterized by more aggressive policing may be a risk factor for poor mental health in this population. So, as the ways in which information is gathered have evolved, so have the ways in which people have analyzed them. For example, this is a recent study that was just released. Quinn Nguyen and colleagues analyzed 16 million Google Street View images of street intersections across the US. And what they found was that those areas characterized as rural had higher obesity, diabetes, premature mortality, physical distress, physical inactivity, and very poor self-rated health. So in summary, I think we are entering a new era of social science measurement and health research. Most of the work that's been done so far, specifically in the area of minority health, has relied on self-report measures of individual experiences of things like hate crimes or discrimination or bullying and stereotypes. But really, this is just the tip of the iceberg. Big data science approaches have enabled us with new tools to look below the surface, including at institutional policies and structures, laws, and cultural attitudes at the population level. But again, these are just tools to help uncover these social and health inequities, and it really is still up to us to decide whether or not to act. Thank you. Wow.